International Journal. Today's talk is on updates in intervention cardiology with focus on TAVI and left atrial appendage closure.
Hello. Can you see my slides? Hello, everyone. Can you hear me?
Yeah, Ajay, we can hear you loud and clear.
Okay. And my slides?
No, not yet.
Okay. Let me share desktop. Okay. Can you see my slides now?
Yes.
Wonderful. Look, sorry about this. I knew this will be slightly tricky. First of all, many thanks to organizing team and you guys for asking me to give this presentation. And secondly, what a wonderful talk by Dr. Joseph and Takayasu, such a rare disease. So that was really good. So I have a hard act to follow now, follow him. So I'm going to give an update on structural heart intervention. And now structural heart, as you will see in my initial slides, is very, very vast. You know, in last 15 to 20 years, in probably my lifetime or my growth of interventional cardiology career, this has expanded right in front of our eyes.
Ajay, can you hear me? Could you go to the presentation mode? We are seeing.
Okay, is that better?
That's good. Thanks.
Sorry, thank you about that. Yeah, thank you for pointing out. So, you know, we can divide structural heart into congenital valvular appendage closure and then septal ablation. I've kept just as another separate thing. In congenital, of course, PFO closure is one of the main ones we do in Western world, but in India, especially in pediatric population, there is a lot of ASD, VSD, PDA closures, coarctation, and then various fistulas you can treat with coil and device closures. Valvular is one of the key things we deal with in adult cardiology. Aortic valvuloplasty and TAVI, of course, the main theme now in large numbers all over the world, including India. In mitral valvuloplasty, you know, nobody can match the numbers done in India. But for mitral regurgitation, there is transcatheter edge-to-edge repair and transcatheter mitral valve replacement is on the horizon. For tricuspid valve, exactly mimicking mitral valve interventions with edge-to-edge repair or TriClip as it is called, and transcatheter replacement as well. For pulmonary valve, there is valvuloplasty and valve replacement and valve-in-valve procedures, which have now come up since evolution of TAVI. For any biprosthetic valve in any of the four positions, we can quite reliably and predictably get good result by putting a transcatheter valve inside the pre-existing biprosthetic valve. In other, I've divided appendage closure and septal ablation. And I'm going to focus mainly on TAVI and LAA as I was talking to your organizing team. I think talking about all of them and very briefly will do no justice to any of the devices. And I think TAVI is most relevant. I had some slides on PFO, which I have now moved to the end because the previous speaker spoke about the PFO during their stroke talk, so I don't need to repeat that. So TAVI is, you know, we started in many years ago thinking, is it even feasible? But over 20 years, it has seen massive change in the landscape where we go from. So lots of clinical trials. Question is being asked now, is TAVI actually superior to surgery in certain subgroups? What are other indications for TAVI? What is minimalistic approach and what is the future holds for TAVI? So divided into these subcategories, and I will try and go through as quickly as I can. In Western world, aortic stenosis is the most common valvular heart disease. You know, I've done TAVIs for so many people in their 90s. I've lost the number. You know, initially I was counting them, but very highly functional 90 people in 90-year-old, including a recent lady I did who is still working as an architect, has her own company. And before going in the cath lab for the procedure, she was still designing a house. And she told me to, or she warned me not to make sure she comes out well because she has to finish this house. So a lot of noctogenarians we're doing TAVIs on. Natural history, I don't need to tell this audience, you know, once you develop symptomatic aortic stenosis, 50% mortality at 12 months. So very lethal disease unless treated quickly after they develop symptoms. This was the first antegrade TAVI done by late Professor Kribier in 2002. They had done it antegradely though. So they came, because that's how most of the procedures were being done that time. So from femoral vein through transeptal, through the mitral valve, and then into the aortic valve. And as you can imagine, it was not easy procedure to do in this already very frail patient. Initially, there were two main devices being used, Edwards Sapien balloon expandable device on the left of the screen, and on the right of the screen was the core valve, which was a self-expanding valve. And since 2002, it has come a long way. We are on to fourth, fifth generation devices. The way we do commonly, and I'll come to that, access point is transfemoral, which is femoral artery, or as commonly known as retrograde approach, now coming backwards. We got repositionable devices, and CT, TAVI CT as it is called, has made life very, very predictable in predicting outcomes and being able to minimize complications. Because of that, we have smaller profile devices, less risk of aortic regurgitation, vascular complications are minimal, and less need a pacemaker. We've understood if we deploy the device more deeper into the LVOT, you are more likely to get pacemaker requirements. So we try and deploy them higher up. These are the currently used devices. Edwards Sapien 3 Ultra, Resilia. Now, Sapien 3 Ultra has been used commonly everywhere. Resilia is a newer version, which is a different way they treat the leaflets with anti-calcification material to improve the longevity of the valve. Medtronic Evoluto FX system. And again, you've got a stent frame, the leaflets, and there is a outer skirt to minimize the risk of aortic regurgitation. And Navitor, the Abbott vascular, have the device as well, which again, stent frame, the leaflets, and outer skirt to minimize aortic regurgitation. In terms of TAVI trials, I say, you know, in cardiology, we like to do evidence-based therapy, and TAVI is one of the best studied topics in cardiology. Lots of randomized trials, you know, initially partner trials, and then Medtronic did many trials as well. More recently, TCT a couple of weeks ago came out, early TAVI trial. I have a couple of slides on that at the end. And there have been trials being done for TAVI in people who have moderate aortic stenosis but have symptoms. So initially, you know, when it was new, we didn't know if it was a good thing or a bad thing. And I was fortunate enough to be part of all this evolution during when I did fellowship. We did the first 100 retrograde TAVI cases in Vancouver with Professor John Webb when nobody else had done the retrograde TAVIs. So proof of concept was in this trial, the partner one trial, where medical therapy at 12 months at 50% mortality versus if you did something still at 12 months, 30% mortality, because initially it was being done in very, very comorbid patients. This is with the core valve, the self-expanding valve, again showing very similar improvement in mortality. Stroke rates were less compared to TAVI versus surgery. This was a core valve data showing TAVI versus surgery. And if you put both together, all-cause mortality with stroke, you can see at 12 months, at 24 months, and at 5 years, the difference or TAVI is favored compared to surgery in all of these. Then came the second generation devices and came partner 2 trial, more than 2,000 patients. It was done 2011 to 2013, which sounds ages away now. And this was the conclusion of that intermediate risk, that TAVR was similar to surgical in terms of primary endpoint of death or disabling stroke. And this really initiated chain of events where TAVI went into the next stage of very significant or exponential growth. And we were achieving these kind of results with Edwards S3, all-cause mortality to 0.9%, stroke risk 1% or less, which was better than even surgical numbers. Then came partner 3 trial, which was really opening up. So initial trial was very high risk patients, and then intermediate risk patients for surgery. And then came the low risk, basically all comers, patients with aortic stenosis randomized into surgery versus TAVI, 1,000 patients between 2016 to 17. Mean age, as you would expect, was younger. STS score was low. And again, it was a composite endpoint of death, stroke, or rehospitalization. The results were nothing unexpected, really, because TAVI procedure had refined quite well in these 10 years from first trial to this trial. You can see the composite endpoint was quite significantly different, 15 versus 8%. And then if you look at death from any cause, that was not a huge difference, but still in favor of TAVI, 2.5 versus 1. For stroke, it was 3.1 versus 1.2% at 12 months. And rehospitalization was the big difference, 11 versus 7.3%. As expected, new onset atrial fibrillation was much more in surgery, as you can see here. Length of stay was, again, significantly more in surgery. So comorbidities as well as hard endpoints were in favor of TAVR. And since then, really, it has taken off, TAVI, all over the world. So the partner trial was using balloon expandable device. This is self-expanding device. Again, low risk patients, about 1,500 patients between 2016 to 18, and very, very similar results. I will not bore you too much with this, but I've summarized it in this slide. Stroke was less, bleeding complications were less, acute kidney injury was less, AF was significantly less. However, there was more incidence of moderate to severe aortic regurgitation. Now, this trial was done using Evolute valve, which has now since then gone into 2 more iterations, and it has got outer skirt. So Evolute R and then Evolute FX devices, which have significantly reduced these both complications. So aortic regurgitation is much less now, and permanent pacemaker rate have dropped into single digits, very similar to surgical numbers. And what was interesting, because this Evolute valve it's called a supraannular valve. So the valve leaflets sit above the annulus, almost in the sinuses. So you get better gradients and better hemodynamics. So conclusion was that it was non-inferior to surgery. Patient journey, talking about TAVI in 2024, what happens to, say, somebody gets referred to me at Flinders in Adelaide. Patient is seen by a cardiologist and a surgeon. They have an angiogram. We are moving away from angiogram as well, because many times the TAVI CT gives us good enough information about the coronary anatomy, gets discussed at a multidisciplinary team meeting. They come to pre-admission clinic and meet a nurse practitioner or TAVI coordinator, and then they come for the procedure. They get admitted on the day of their procedure. Is done in conscious sedation most of the time. However, some patients prefer to have laryngeal mask or to be out for the procedure. One person with a fellow is very standard. I'm fortunate enough to have a lot of fellows from India. So we do cases with our fellows. If they get intubated or they have laryngeal mask, will be removed on table. They're mobilizing a few hours later and get discharged the next day, unless there is some conduction issues or some complication. We have done few urgent TAVIs now, and we have discharged few patients on the same day. Some patients have insisted on going home because they're feeling so good at the end of the day. Access point, most common is transfemoral retrograde approach, as I said at the beginning, but then all options are open, subclavian, direct aortic. Transapical is not really feasible anymore because Edwards has stopped making the device. Transcarotid and transcaval, which is coming from vena cava, getting access into the aorta and then doing the TAVI. What is minimalistic approach is done in cath lab. You have transthoracic echo, conscious sedation, percutaneous access and closure, no urine catheter or central line, and post-procedure they go to coronary care unit, not to ICU. It is obviously less invasive, quicker return to normal activity for these patients, less resource utilization, and of course reduce cost. And of course, very important that we achieve all this without increasing adverse outcomes. Couple of examples of valve being deployed, though this is doing a rapid pacing. This is a balloon expandable device being inflated with the rapid pacing, and pigtail is being withdrawn here, and you deploy the TAVI device. And this is an aortogram after the procedure showing this is the stent frame nicely expanded and the valve leaflets are working. This is echocardiogram showing severe left ventricular hypertrophy here, very stenosed, restricted aortic valve leaflet motion. And this is afterwards. You can see this bright shadow of the TAVI device. Leaflets are hardly visible because they are very new, thin leaflets. This is the self-expanding device. So the way we deployed is, one good thing about this device, it is retrievable. So you can see on the screen on the right. So this is at the beginning while I remove the sheath or unsheath the valve from here. You can see this marker now has come up to there. The valve has been unsheathed and it is open now. And up to this point, if we are not happy with anything with the valve, we can rewind back and reposition or take a different valve. But once we are happy from here, then you will deploy the last 5 to 10% of the device. And this is a aortogram showing after the procedure, the valve has been deployed. This is somebody who had a mechanical mitral prosthesis before. We analyzed the CTs very carefully to make sure there is enough space in LVOT area between this mitral valve and the new device which is going to sit. And you can see this balloon expandable device being expanded to deploy the valve. And then you will see you can see the mechanical mitral leaflets very well functioning. We did this under TOE guidance just to make sure that we could assess the mitral valve very well. Got a very good position of the aortic valve and not really interfering with the mitral ring. And this patient did very well. TAVI within failing surgical bioprosthesis is very, very commonly done now all over the world. This is a Medtronic mosaic bioprosthesis which had failed. And you can see here TAVI device being deployed inside that. And this is a post-aortogram after the procedure showing well-seated device. This is similar Medtronic mosaic bioprosthesis, but we are using a self-expanding valve. Being supraannular, you get better hemodynamics and better gradients. This is a transvenous through transeptal approach, transcatheter mitral valve in valve inside a surgical bioprosthesis. This is an epic bioprosthetic valve. And we are deploying this Edwards valve inside here. Obviously, we have to remember to put the valve upside down when we are mounting it on the catheter so that it will open in the correct direction. In terms of antiplatelets, aspirin is enough nowadays. We do patients with high risk of stroke, sometimes give them clopidogrel for a little bit. And if patient is on warfarin or DOAC, then of course we use that and antiplatelets are not required. We follow them up usually at 4 to 6 weeks to make sure, repeat the echo and make sure everything is all right. And then we see them a year later and then usually discharge them. So in 24, most of the parameters are now favoring TAVI compared to surgery. And the big elephant in the room or unanswered question is durability. We still believe it should last for 10 to 15 years, but what next is a big problem. So doing them in very young patients, they would most likely then end up with surgery when they're a bit older. So we call this lifetime planning, and we have a very careful discussion at MDT as well as with the patient and the family before deciding, somebody who's 65 might end up with 2 or 3 procedures, and you need to divide and discuss with them various options. Either you do 2 TAVIs or whether you'll do a TAVI, then surgery, then TAVI, or you do surgery now and then do a valve-in-valve TAVI. So various permutation combinations are possible. Cerebral protection device trials were negative, but we use common sense. Somebody who is clearly at high risk of embolic or valve-in-valve procedures, for example, with loose friable segments on the valve leaflets, we use a cerebral embolic protection device to minimize the risk of stroke. We obviously want to stay away from offering TAVI, which is still very expensive technology, to futile population, which would be dementia or they're bedbound, very cachectic. I've got this ABCDE short form, people who have end-stage malignancies, then you could do palliative balloon valvuloplasties rather than TAVI for them. Since 2008, we started doing TAVIs. We've done lots of cases. On average, on a Tuesday, at Flinders, we call it TAVI Tuesday. We do 6 to 7 cases in a day. Length of stay, more than 90% get discharged. Then for next day, readmission rates are very less. For many years, our 30-day mortality has been 0. MACE has been 0 for a while. And credit to the team, we work as a team, cardiology, radiology does the TAVI CTs, vascular surgical team helps us in difficult vascular access, TAVI coordinators, and so on. There are a few trials going on, and I will just very briefly mention early TAVR trial, which was presented at TCT, one-to-man, one randomized patients of TAVI versus clinical surveillance for patients with asymptomatic severe aortic stenosis. And superiority endpoint was composite of death, stroke, and unplanned cardiovascular readmission. At minimum follow was 2 years, and you could see no surprises again. Compared to clinical surveillance group, the TAVI group did better at 2 years as well as at 5 years, and p-value was significant. Median time to conversion, asymptomatic becoming symptomatic and needing procedure was about 11 months, and number needed to treat was 6 at 2 years' time. These are individual endpoints, all cause of death was not hugely different. Stroke was little less, and big driving factor, again, not surprising, was unplanned hospital admission, because people who are under clinical surveillance were more likely to present with symptoms or heart failure compared to those patients who received the TAVI. I might take a pause there and talk to the panelists and moderator. How am I going on time? Should I briefly talk about LAA closure, or you want me to stop there and take some questions? Happy with whatever you feel more comfortable.
After that, we'll take questions.
Okay, so I'll keep going with the LAA. I will try and be as brief. It is a talk in itself. So left atrial appendage closure, I don't think it has taken up in India as much when I speak to my friends, but it is quite big numbers in Western world and I suppose it is a reflection of elderly population with more likely AF and more risk of bleeding problems, so they cannot take anticoagulation. So as you know, in Australia, just talking about Australian numbers, 5% of the population above 55 can have AF. And as you get older, it is much higher risk. And this is the problem. I'm not sure this is going to play. No, it's not playing, but you can see here clearly on transverse picture, left atrial appendage and the thrombus there. We know that more than 90% of stroke causing clot are from left atrium or left atrial appendage. And that is where the rationale is. If we can close the left atrial appendage in patients who cannot take anticoagulation, we will reduce the risk of stroke. Oral anticoagulation use, even in Western world, is not 100%. As for various reasons, patient compliance, or patients have bleeding problems, or patients get bored after a year or two and don't want to take tablets. So nearly 40% patients who should be on oral anticoagulant are not really taking it. So what we do for this. So just talking briefly about the device, the one device I'm going to talk about is Boston Scientific device. There is a Abbott device called Amulet as well, but my predominant go-to device is Watchman device, as it is called, or as it is called Watchman FX device now. So the way this device comes, these are just briefly talking about the device. It has got these are tines or spikes, as you call them, but in the newer version, they are much softer now. So the risk of pericardial effusion or tamponade is much less. And there are double row of anchors, which helps reduce the risk of embolization. And this is a movie, if it is going to play. No, it is not going to play. Apologies about that. But this is just a schematic representation of the procedure where you deploy the device. Until you release it, it is repositionable. You can assess on the transesophageal echo if you have achieved enough occlusion and compression of the device. So you want to achieve between 15 to 20% compression. And you want to make sure there is no residual shunt on the sides. This is a TOE guided procedure. And if there is any concern, you can remove this device and go with the new device or a different size device. Circumflex artery is one of the very important parameters you look at when you're looking at various angles on the TOE. So it's a one-time implant. It's done in cath lab, and it's a transvenous access procedure. And these are various pictures. You can see it, various stages. It looks like an apple sitting in the appendage once you have done the device. And these are various views on the TOE showing the device nicely compressed inside the appendage. You look at the shoulder here, make sure not too much device is protruding. And you look on the color flow that there is no significant residual shunt. We do a tuck test to try and pull the device slightly, make sure it is well secured and the tines have secured inside the appendage. Case example, this we do various measurements. It is again, as I said, TOE based procedure. You look at the TOE images, and you can also do CT now for sizing in patients who have difficult TOE images. We do a cardiac CT to guide us where the transeptal puncture would be, and also to choose the device size. This is a couple of images of the procedure, transeptal puncture. We want to be inferior and posterior so that you can have a straight shot from here into the appendage. We again like to do it under TOE guidance so that you get a precise puncture in so that you can access the appendage easily and you're not struggling. Then there is a delivery system is placed over the extractive wire, and then a pictal injection is done to get to measure the size on fluoroscopy as well as on the TOE. Then this is the device is coming through, the sheath is, so there are various ways you can either hang the device, hang the sheath halfway in and half out and slowly deploy the device, and you can gently push it in towards the end. Or you can do what is called withdrawal method, where you have the delivery sheath sitting almost at the end. You don't want to be right at the end, otherwise you get tamponade, and slowly withdraw the device, withdraw the sheath so the device will be deployed. And then this is the device being deployed, and you do an angiogram to make sure there is no residual shunt. As you can see, there is no real flow going inside the appendage anymore. And TOE, of course, is a very important assessment. This is a tuck test. As I told you, try and pull the device a bit and then push it back in to make sure it is not going to pop out. If it does, not end of the world, you can retrieve it and then go again. This is a tuck test being done on the TOE. You can see all you're pulling is just the top end of the device. The bottom end is nicely stuck inside the appendage. And this is device being released, final release. These are nice 3D, three-dimensional images of the device being seen en face. And these are various angles, again, showing the device nicely seated. And, there are lots of trials being done since 2005. Protect AF was the first one, Prevail, and then, more than 3,000 patients with more than 9,000 patient follow-up. And adverse events, as I said, the device has modified, and initially almost 10% complication rates have gone to even less than as shown in this trial. It is very rare for us nowadays to have a problem with appendage closure procedure. It's considered very safe. And again, patients will come in on the day, have the procedure, and they go home the next day. And this is summary of the various trials. I'm not sure why this slide has come quite faint. And various trials have shown, meta-analysis of PROTECT AF Prevail at 5 year has shown that if you do the closure, you will be better off than using anticoagulation, and especially those patients who have contraindication for anticoagulation, for them, obviously, doing appendage closure is a significant advantage. Of course, they should have elevated CHA2DS score. So 6 months post-procedure, freedom from bleeding, not unexpected, there are various combinations. Let me see if I've got that slide about what antiplatelet or anticoagulant to use after the procedure. There are a lot of anecdotal cases where patients cannot take anything, not an antiplatelet, not an anticoagulation, because of recurrent either hematuria or GI bleeding. Melena, we see most of the time, are the two reasons patients cannot take anticoagulation. But usual recommendation, if you can take for 3 months, is anticoagulation, and after that you can go to single antiplatelet agent. Again, I will not, looking at the clock and already your session is running, I will not go into too much of the more recent trials, but as you can see here, just I would like you to focus on DOAC plus aspirin for 45 days or aspirin plus clopidogrel for 6 months, followed by aspirin independently, are the various ways we use. We like to do a TOE at about 45 days to look at how the device is sitting, anything had changed. And then at 6 months and 12 months, apologies about my typo here, we do only transthoracic echoes to look at, see what is going on. In this trial, the implant success was, 400 cases, 99% success. Unsuitable anatomy, as you can see, was very uncommon. And device sizes, all sorts of sizes were used. Commonest use was 24mm device. And safety endpoint was 0.5%. What we can see in various trials, and as the experience has grown for the using the appendage devices, complication rates have dropped and procedure success rates or safety for the patient has gone up with time. So this was published in 2021 in NEGM, and again showed very positive results for LAA. Very briefly talking about surgical appendage closure, especially if patient is going to have open heart surgery for something else, then there is a definite rationale to close the appendage if you're going to go for, say, CABG or valve replacements. And this was surgical trial, patients with AF with CHA2DS risk of 2 or more who were undergoing cardiac surgery for another indication, almost 2,400 patients. And they were randomized into surgical occlusion versus they did not do the standard recommendation where you don't touch the appendage. Mean age was 71, mean CHA2DS risk score was 4. And as I said, more than 2,000 patients. And what you could see here, cumulative incidence of complication was clearly less in patients who had the occlusion compared to non-occlusion. And this is up to a 5-year follow-up. Hazard ratio was 0.67. So oral anticoagulation use was 75% in the occlusion group and 78% in non-occlusion group. So it was, anticoagulation use was very similar, but clearly less events in patients who had occlusion. So it seems like that benefit was additive to the anticoagulation therapy. What we don't know is, and I ask this question to my surgeons who are doing this quite commonly now, is patients with AF, and if they've done the appendage closure, should we continue anticoagulation or not? And we don't really have the trial evidence for that yet to stop anticoagulation. And unless the trial does not tell us, so I don't think we will be game enough to stop anticoagulation in patients who have had surgical appendage closure. So conclusion is of the trial was significant reduction in primary endpoint, there was no adverse or extra price to pay in terms of mortality or stroke. I think I'll stop there. Thank you so much.
Thank you, sir. On to the next talk, we'll take some questions on Dr. Ajay
Right.
Sinhal talk.
Very happy to. Yeah.
Any questions? We have one question here. It's one participant has asked, what do you recommend for a 30-year-old person for moderate symptomatic aortic stenosis?
38,
30.
30-year-old. Yeah. So look, I think that recommendation hasn't changed. So first thing we have to decision here, there are two parts of question here we need to answer. So one is 30-year-old, suppose he had severe symptomatic aortic stenosis, what would you do? Recommendation is still, if patient is compliant, then you do mechanical aortic valve replacement, and that would be one-time procedure for the patient, and probably that will do well. And about the moderate aortic stenosis is a controversial question. If you have moderate aortic stenosis, no symptoms, of course you continue surveillance by serial echoes and symptoms. And if you have symptoms with moderate aortic stenosis in a 30-year-old, my take on that would be depending on how moderate it is, right? Is it more moderate to severe, or is it more mild to moderate aortic stenosis? If I'm convinced patient has symptoms because of aortic stenosis and nothing else, then natural history of this is probably within the next 12 months he is going to need the valve replacement anyway. So rather than they getting into serious trouble, and you're talking 50, 60 years of life for this patient, so 1 year is not going to make much difference. So I would then go ahead and treat them. But there's a trial going on at the moment. We participate in the trial, progress trial. Moderate aortic stenosis patients with symptoms were randomized into two groups, TAVI versus wait till AS gets worse. And that trial will give us more answers to this question, whether it is worth treating moderate AS patients or we wait.
Thank you, sir. I don't think there are any further questions from the audience. I ask for a comment from the interventional cardiologist over here.
Thank you. I'm Dr. Vijay. Ajay, very lucid talk. Thanks for update on the TAVR scenario currently in Australia. I think the Indian numbers are increasing, and the valve-in-valve procedures as well. And in terms of your planning for the coronary artery intervention with this concurrent disease, do you do it at the time of your TAVR procedure, or you try to do it before?
So look, we must say we've been trying to do that before, and only if patient has angina or they have left main or proximal LAD or proximal RCA we are treating. Say asymptomatic circumflex lesion, we don't treat, or if it is distal LAD, we are not treating them. And the main reason to do them two separate procedures is if you've just put a stent in and you do the vascular procedure with a large bore sheath, and there is a bit of a vascular complication and you want to use protamine or things like that, which is again not essential, but we try, and plus the contrast load, many patients are elderly patients and contrast load can be an issue. We tend to do radial access procedure 2-3 weeks before, make sure kidneys are okay, and then bring them back and do the TAVI as a separate. But there are some patients who travel, 600, 800 kilometers for the procedure. In them, we do it at the same time.
All right. I think any more questions from the audience? If not, we'll close the talk. And thank you, Ajay, again for your time. Once again, on behalf of the medical fraternity from CMC Vellore, thank you.
No, my pleasure, Luke. And CMC Vellore in Adelaide has a massive connection, and Dr. Joseph will be witness to that. Lots of his trainees are working as fellows and consultants in Adelaide. Adelaide has this special connection. Lots of from medicine as well, not only cardiology, we have lots of people in respiratory, in general medicine. It feels like CMC Vellore has a second home in Adelaide.
Thank you, Ajay.
Thank you. Bye. Enjoy the rest of the meeting.
We will now move on to the next talk from cardiology.